This is GIT presentation number 16 for diffuse liver disease and hemochromatosis, prepared by Prof. Sharaf and advised by Prof. Hani Sami. You all know about the segments of the liver. We start to see that the liver anteriorly is 2 and 3. If you go backward, it is 4A and 4B. If you go more back, it is number 5, 6, 7, 8. 5, 6, 7, 8. So 2, 3, 4, 4, 5, 6, 7, 8. If you look here, we consider the anterior part or the left lobe is 2, 3, 4, 4. Then if you are in high cuts, you will find 7 and 8, but in low cut you will find 5 and 6. So 2, 3, 4, 4, 5 and 6, then 7 and 8. What makes it is the levels of the cut level. For example, if you are cutting within portal radicals, that means you are down, you are near to the hilum, and this will be 5 and 6. But if you are cutting within hepatic veins, that means you are going to the inferior vena cava, that means you are high up, and this will be 7 and 8, 7 and 8, 7 and 8, 7 and 8. So the level determine which segment we are, at which segment we are. And don't forget that at lower cuts you don't have 7 and 8, you have 5 and 6, 5 and 6. The counting is from 5, 6, and then 7, 8. So it is, we have here the hepatic vein levels. So this is 2, 3, 4, and there should be another 4 here, 4A and 4B, then 7 and 8. Same, 1, 2, 3, 4, 7 and 8. This is number 1, or the caudate lobe. 3, 4, 4, 5, 6, 3, 4, 4, 5, 6, and this is number 1, as we said. Now, what about this area? This the right portal vein. So we are in the level of the 5 and 6. If we are in the we have hepatic veins, we are in the level of 7 and 8. Now what is this? Here we have the right lobe atrophic, and it's replaced by some intestine. We have 2 images. This is the left lobe. The left lobe is hypertrophic in comparison to the right lobe, and the gallbladder is posteriorly located. There is dilated right hepatic duct. The kidney is rotated. There is a lot of loops in this area, but there is another observation that what should be lung is replaced by liver and intestine, and still there is well-defined outer margin containing all these together, giving the rise to the possibility of diaphragmatic defect and intrathoracic position of the right lobe of the liver with rotation of the kidney and replacement of the atrophic right hepatic lobe with intestinal loops. Here the reverse, the left lobe is atrophic, left lobe atrophy. Contrast CT, absent left portal vein, there is nothing here, and absent left lobe. Now this is a famous post-biopsy exercise. As you put your needle, you might traverse a vein with an artery, making a small fistula inside, and if you do, you will find an AV fistula developing, and this is called the maximum intensity projection, which gives a better view. It's a post-biopsy arterioportal or arteriovenous fistula. Another one, post-biopsy fistula. This is a case of liver laceration with fluid accumulating within the peritoneum, intraperitoneal fluid collection. Spleen is enlarged, liver is small and shrunken, and cirrhotic. Portal vein is very wide. Typical appearance of portal hypertension induced by schistosomiasis or bilharziasis. T1, T2 coronal images shows the enlarged spleen with normal sized liver and dilated portal vein. Radiation hepatitis will produce this injury. The differential diagnosis of this injury is a subcapsular small hematoma or deposits. So this can be produced by radiation from breast or deposits from any other site within the pelvis, and subcapsular hematoma is another possibility. This is a typical cirrhotic liver with nodular outline. Here we can say that this is macronodular appearance. This is the enlarged spleen, and we should be careful that the spleen is cut only in 3 ribs. Here it was cut in 5 ribs. 1, 2, 3, 4, 5. 1, 2, 3, and then outside the confinement. That means it is below the costal margin. The spleen should not go until to be felt beyond the costal margin, and the spleen should not be projected against more than 3 ribs, as it is oriented obliquely the same way, the same axis as the direction of the ribs. So this is a case of splenomegaly, and we have many vessels engorged. This is perigastric and gastroesophageal varices, or what we call congestion due to portal hypertension, associated with the typical cirrhotic appearance of the liver. a heterogeneously enhancing liver with large enhancing nodule. This is the appearance of the dysplastic nodule. So we have malignancy, dysplastic, early enhancement, and we have here the multiple regeneration nodules. Axial T1 in phase and axial T1 out of phase. Here we have the lower signal intensity of the liver and spleen compared to the out of phase here due to iron deposition. So remember that iron makes marked hypodensity of the liver in T1 weighted images and compared to the T1 out of phase image. This is a low intensity of the liver in relation to the skeleton, to the muscles. The pancreas is normal in intensity. And this is a coronal showing the liver and spleen with its incidental left hydronephrosis. Again, this is due to due to iron deposition. This is a case of iron overload in a baby with anemia and multiple transfusions. Markedly hypointense liver and spleen. So again, due to the overload, iron overload, we get this appearance. So marked low intensity of the liver and spleen is seen in iron deposition. Iron deposition diseases are classified into primary hemochromatosis, which is idiopathic, or secondary hemochromatosis due to multiple transfusions, or ineffective erythropoiesis as in a response to anemia. So either response to anemia or response to the transfusion in case of anemia, overload or ineffective erythropoiesis. These are the types of hemochromatosis. Secondary hemochromatosis, which we said as due to either transfusion or ineffective erythropoiesis in anemias, we'll see that it is either due to multiple blood transfusion or due to anemia. Excess iron accumulates in reticuloendothelial cells. Pancreas and myocardium are spared. The treatment is iron chelation therapy. Secondary hemochromatosis is as ineffective erythropoiesis. Inappropriate hyperabsorption of iron similar to primary hemochromatosis. The mechanism is unknown. Excess iron accumulates in parenchymal cells but may also be seen in reticuloendothelial system due to multiple transfusions used in treatment of these cases of anemias. The primary type is autosomal and presents in 5th or 6th decade, and there is increased risk of hepatocellular carcinoma untreated diseases progress to cirrhosis and liver failure. This is a primary type, which occurs late in life. Primary hemocirrhosis T2 and T2 star in the liver compared. This is T2 and T2 star, or the HAST. Compared to the muscles, it is low. Decreased cellular intensity due to iron, and this may, in the primary type, may affect pancreas and myocardium. Spleen and bone marrow are spared. So the spleen in primary type is spared, while the pancreas in the primary type is spared. So in the secondary type is spared. So in primary type we have the liver alone, plus minus pancreas. In the secondary type we have liver and the spleen, and no pancreas and no myocardium. Diffuse liver disease, this is axial T1 in phase. This is axial T1 T2 star or T heavy T2. This is hemochromatosis, different appearances in different sequences. Axial T1 in, axial T1 out, definitely is lower in intensity. In coronals, this is the appearance of the primary. This is appearance of the secondary, where we have enlargement of the spleen, different types of hemochromatosis, and this is hydrolymphatic left kidney by chance is noted. Thank you.